3 of research grand rounds. The menu today is here that I'm going to give you 5 board questions to think about and talk about. I'm going to review a paper by one of our faculty members, actually one of our residents too. Jacques was the co-author on the paper that I'm dealing with today. Yeah, that's the guy. The main event today is a partnership between Bill Ledoux, who is our guest here. Bill is a basic scientist who has an adjunct appointment in the department, and Dr. Sangeorzan on using cadaveric gait stimulation to conduct orthopedic foot studies. And I want to just finish the day with talking to you about encouraging you to apply for outside research grants and talking a little bit about that. So let's get right into the board review. I've chosen 5 questions from different areas, and these will accumulate through the year, and they might be a little different from the reviews that you usually have from your other faculty. Some will be the same, but they'll be available to you to review. So this question, and these come from OrthoBullets. 34-year-old male is an inpatient at a rehab hospital after sustaining severe lower extremity fractures in a motor vehicle accident. As a result, his energy expenditure while ambulating is 40% above baseline after being fitted with an appropriate prosthetic prescription. What is this patient's most likely lower extremity amputation level? So is he either a long or an average unilateral transtibial? Is he a bilateral transtibial, a unilateral transfemoral, or a bilateral transfemoral? The question's a little bit odd until you get to the last sentence, because it doesn't say that patient had an amputation, but the last sentence tells you that it is. So anybody got any ideas about this one? What is the likely answer to this question? 3. Bilateral transtibial. Good shot. Somebody knows their energy expenditure. That's the right answer. And here from the literature that they quote are some rough figures for you that you could probably take away from this question. That if you have a unilateral transtibial, this could increase your energy expenditure in gait between 9 and 25%. That variability is likely due to level. If you have a bilateral transtibial, 40%. If you have a unilateral transfemoral, anywhere from 49 to 65%. Now the literature that they base this on is very old. Notice that this is a 1979 paper and a 1975 paper, but that's what they've got, and those numbers in the diagram might be useful to you. All right, one on bisphosphonates. What effect do bisphosphonate medications have on spinal fusion surgery when taken in the post-operative period? Is it that any effect can be counteracted by taking calcium supplements? Is there no effect? Is there an increased risk of wound infection? Is there a smaller fusion mass? And is there decreased fusion rate? How about that one? That's the wrong one. And it's a kind of trick, actually. You'd think it would be the right answer.
Which didn't make sense about
Yeah, one is very unlikely because bisphosphonates have no effect on calcium metabolism. They work on the osteoblasts, osteoblast fringes. That it would have no effect is also very unlikely because we know that bisphosphonates are critical in inhibiting bone turnover. This one's totally unlikely because bisphosphonates have no known antibacterial effect, and so it does come down to these two. And this one's a bit paradoxical because you'd think that if there is a decreased fusion rate, which is the right answer, you'd think also that there'd be a decreased fusion mass. But in a study of, these are the things we've talked about already, let's get down to the one about, yes, that in a placebo-controlled study, they found that the fusion rates for placebo were actually greater than the alendronate group. and that osteoclasts do not affect, obviously they affect osteoclasts and don't affect calcium metabolism. And this is an interesting one. It says that there is no formal recommendation of when to stop bisphosphonate therapy prior to spinal fusion surgery. We don't have a spinal surgeon here today, and that may have changed, but this was as of 2009. But it's a very interesting observation, of course, that you don't want your spinal surgery patients recently on bisphosphonates. Bisphosphonates, you'll recall, have a 10-year half-life, so they really stick around. And probably in the next 5 years, bisphosphonates will be history, and we'll be seeing drugs which have a more targeted effect, rather like a switch than a long-term effect. And these are the references to that. Notice that they are all animal studies. How about this one? What term in statistics defines accepting the null hypothesis when it is in fact not true? Is it a type 1 error, a type 2 error? Is it bias? Is it negative predictive value? Is it positive predictive value? And this one you either know or you don't. You know, you can't rationalize this one because it's an arbitrary naming. And the answer is that it's a type 2 error. So that occurs when you accept the fact that there's no difference between two treatments, but in fact there really was. So you have missed the effect here. Now let's look into some of these things a little more. Type 2 errors can be minimized by making sure that the study is properly powered. That is the most frequent reason for you rejecting the hypothesis when it's true. Supposing you have a medication and you take 2 control patients and 2 medication patients, and one of those patients has, wildly discrepant response, there's no way you're going to show the main effect because you just don't have power to show it. So adequate power is the way to overcome a type 2 error. This one's pretty interesting, that Lochner looked at the rates of type 2 errors in 117 randomized studies of fracture healing. And they found that in many of these trials, the type 2 error rates exceeded accepted standards. So basically they're saying these trials were really not adequately powered. And so a lot of the orthopedic literature on fracture, you have to take a look, be a little bit circumspect, because the power may not have been adequate. Now, the question also, of course, needed you to know about the difference between positive predictive value, negative predictive value, also something about sensitivity and specificity. And these can be also difficult to get your hands around. And so this little table is extremely useful to you. And this shows that with a positive test, this could be either a true positive or a false positive. With a negative test, it could be a false negative or a true negative. The presence of disease could be either present or absent, both false and true. And the way I like to think of these two tests is this, that the positive and negative predictive values, they describe the test. They're not talking about the disease, they're talking about the test. So the way you calculate it is going to be on the test line. So if you want to know the positive predictive value, you're going to say, okay, it's the true positives over all the positives, false and minus. So it's A over A plus B. In exactly the same way, the negative predictive value of the test is going to be on the test line. So it's going to be how often it's true negative over all the negatives. Okay, so think about positive and negative predictive value being about the test. However, think of specificity and sensitivity of being about the disease. And so they're going to be probabilities calculated from the columns. So the specificity for the disease is going to be true negatives over the sum of all disease negatives. And similarly, sensitivity is going to be the true positives over all of the disease positives. All right? So I think if you just capture that table, which is easy to write out from scratch, and think about positive predictive value and negative predictive value being about the test, and specificity and sensitivity being about the disease, then you've got it.
Okay, not to interrupt, but when I took my recertification exam, there was a whole page. If you had had that grid memorized, you would have flipped through this page of tests. There's probably 10 questions related. And all you needed was that grid to answer correctly.
How'd you do?
I managed to pass.
Good.
But not because of that series of questions.
Yeah, it's very confusing, and I think that grid will help. Okay, here's one on material properties. Very often asked, which of the following materials has a Young's modulus, and they say Young's modulus of elasticity, that is most similar to cortical bone? Is it titanium? Is it zirconia? Is it stainless steel? Is it ceramic? Or is it an alloy of cobalt, chromium, or molybdenum? Nathan? You're right, but I think this is a highly confusing question, and I'll tell you why. First of all, let's just, I guess that could be said about all the questions. Let's just review Young's modulus. So when you load a material, and this is a material test, not a structural test. Structural test would be where you actually load a component. Material test is where you load a nice little cube or coupon of the material. When you load it, you start off in the elastic zone, where stress and strain are linearly related. The material eventually yields and goes up to its ultimate strength. So all of the questions about Young's modulus deal with this end of the slope. Now, the web page for this question gives you this diagram saying if you look at that part of the stress-strain curve for all these materials, this is how they drop out, with cortical bone being here and titanium being right here. However, this is the confusing part of it. Notice I've put not to scale, because it turns out that if you look at the actual modulus, here's the numbers and here's the graph, you can see that bone is just visible down here, and all of the other things are way, way out there. So it's a little bit deceptive to say, well, you know, titanium is what you go for because it's only 6 times stiffer than bone compared to cobalt chrome, which is 10 times stiffer than bone. So that's why I think the question's not very meaningful, but you're going to be asked it, and titanium's the answer. All right, lastly, on ethics. So you're called to the emergency room to see a male patient with an open displaced bimalleolar ankle fracture. You admit the patient and schedule him for surgery. According to the 2009 guidelines, which of the following scenarios would meet criteria for coding the encounter as a new patient? Could you code as a new patient if you personally injected his knee in the office almost 3 years ago for OA and have not seen him since? Could you code if he had an arthroscopic operation by your partner 4 years ago? Could you code if you were consulted 1 year ago for the same patient's shoulder pain when he was hospitalized for chronic renal failure? Could you code if he was seen by your partner in clinic for a herniated disc 2 years ago? And could you code if you performed a hip replacement on him 12 years ago and his last follow-up visit was 18 months, that's great follow-up, at which time he was doing well? Okay, what's the answer? 2.
4 is also correct. If the partner who saw him was a spine surgeon, not the general orthopedic surgeon.
Or a foot surgeon.
No, foot surgeon is a separate type.
Sports, okay, yeah, I'll just get to that because the answer is actually 2, and the reason for the others to be excluded are these. the 2009 guidelines apparently clarify that the patient can only be defined as new if he hasn't seen anyone in your group in the last 3 years and of the same specialty. Hand and sports, as has been mentioned, with a CAQ, they're an exception, and they're allowed to bill for patients already seen by other orthopedists in the same group. And then the consultation, this scenario would not qualify as a consultation since the surgeon is taking over care that's in progress. Bruce, you have any comments on that?
Yeah, I don't think that last paragraph is correct. So a consultation can see a new patient in the ER who is not admitted to the hospital and consult in response to the ER doc or whoever saw him. You can fulfill the consultation criteria by examining them, making a note and sending it to the referral doc. And then if you decide after your consultation to admit that patient and treat them surgically, that is still okay to do the consultation and then admit them and treat.
That ER docs didn't count as referral docs because they couldn't actually assume care of the patient.
That's not true. So anyone can refer you a patient in consultation. In fact, any of your partners or someone who's in your group refers someone to you for a consultation. The challenge with these questions is they change every year based on who's interpreting the rules, so it's a tough thing to put on OITE.
Yeah.
I was going to ask a question. If there's a closed reduction in passing by an ER physician and then following your clinic, how does that work?
So then, in reality, most of those will need to be redone, but they don't have to be redone. They can just be billed as an E&M when you see them in follow-up.
Okay, thank you for that. I'm glad you were there to clarify, Bruce. All right, stage 2. You remember? Yes. You want to get back to the question?
Oh, no.
You want to give the presentation on this? I'd welcome you telling us a little bit about it. As we go. Correct me if I misspeak, okay? So you'll recall that in this section of the Research Grand Rounds, we will bring to you a recent presentation by one of the faculty members. The rationale for this is for you to get to know a little better what your faculty are doing in their research side of their personality. You may often just know them as being behind a mask and on the other side of a scalpel or an instrument, but they have this other life that we also hope you will have. So this is a paper that recently appeared in Spine, which is we talked about impact factors last time. Spine is one of the journals in orthopedics with the highest impact factor because there's a lot of spine surgeons and most of them can read. And the title is Risk Factors for Medical Complications After Lumbar Spine Surgery, a multivariate analysis of 767 patients. And Mike Lee was the lead author. You see Jacques was the second author, which probably means he did all the work. Amy Cizek, who worked with this session last time, was present on there. So was Dr. Bella Barbara and Dr. Chapman. Now, let's talk about the structured abstract. If you go to this paper, you will see an abstract that's not just a paragraph, a solid paragraph. It's an abstract which has headings. Most journals these days will ask you to do a structured abstract. They don't just want you to write 250 words. They want you to tell them, okay, what was the study design? What was the methodology? What were the limitations? And so when you write your abstract, even if it's not a journal that takes a structured abstract, this is a good plan for you to organize your thoughts. So this study design was a multivariate analysis of prospectively collected registry data. So this was not a fishing expedition into records of patients from the past. These patients, as we shall discuss, were enrolled before their spine surgery, and then they were followed prospectively, for at least 2 years. The objective was to use multivariate analysis to determine significant risk factors for medical complications after lumbar spine surgery. Well, the key issues here are multivariate analysis, as we shall show you at the end. If you only consider univariate analysis, that is, you take, let's say, 30 possible risk factors and you try to relate every one of them individually to the outcome, you will get a totally different answer than if you do a multivariate analysis where you take into account all the possible interrelations between these many variables. Likely, you have much redundancy in your univariate analysis, as we'll see. Lumbar spine surgery is the other key word. So as you'll see, it starts larger than that and then homes down. Now here's the background. So the authors felt that many of the previous studies that had looked at complications after spine surgery had used big national databases, but unfortunately these big national databases didn't have all of the information that would allow you to do a multivariate analysis. The database that they used, which I'll describe in a moment, had hundreds of entries in it, which you just wouldn't find in, for example, necessarily the Medicare or the national inpatient sample. So here's what they did. They looked at the Spine End Results Registry, which is a collection of prospectively collected data on all patients who underwent spine surgery at both UWMC and Harborview. And I think this shows you the richness of the environment that you're in, because you will see that they actually had 740 patients who qualified in a single year. This is a lot of patients. You know, if you were at Podunk Medical Center, it would take you a lifetime to collect this many records, and so this is quite a remarkable collection. The approach to the database is described in this paper by Sohail Mirza, who was a faculty member here until 2008. Complications were defined in detail a priori. They decided what they were looking for, and they were recorded for at least 2 years after surgery. Now here's the enrollment, which is always key in a study like this. So there were 1,745 patients who underwent spine surgery during that calendar year at the 2 locations. That's a lot of cases. 2-year follow-up, 978 of these patients were excluded, and we'll look at the exclusions in a moment. Whenever you see a study like this where there's a lot of exclusions, you have to really carefully look at the exclusions, because the possibility for bias is overwhelming. Supposing you excluded on a criteria that would really mean that every unhappy patient was excluded from the database, your results could be totally meaningless. So of the 767 of this large group who underwent lumbar spine surgery, there were 431 who consented and complied with inclusion criteria. So you can see how it funneled down, and this represents about 24% of all spine surgery patients. And there's a diagram of how it whittled down. So you started with the 1745, 767 were lumbar only, and then 431 of these were in the spine registry, and there were an additional 336 who were in a rather smaller study. The exclusions included those who were less than 18 years of age, those who had a non-lumbosacral site, and you see how that broke down. One of the key tools used was the surgical invasiveness index, and this is a weighted sum of the complexity of the procedure. So the weighting is the number of levels at which anterior decompression, anterior fusion, and anterior instrumentation was done. So if you did each one of those at 2 levels, you'd get 6 points. And then similarly for posteriorly, if you did each one of those at 2 levels, you get another 6 points, and you get a score of 12. For example, a C5, C6 anterior discectomy with fusion and plating would be 5. Now the analysis is where all the meat of this study is, and I won't go into it in detail, and neither could I actually on some of the multivariate analysis, but First of all, there were a number of categorical variables, either present or absent, yes or no, and they were analyzed using Pearson's chi-squared or Fisher's exact test. The risk ratios and 95% confidence intervals for each of these categorical variables were analyzed using, and this is the key, univariate, which is straightforward, or multivariate log binomial analysis. And I've put a paper here if you want to dig into this. This is a very popular approach now, which is thought to minimize the risk of underestimating the result. So they use this method to examine the association between risk factors and complications. And so the model included risk factors that the investigators thought were important. They included known confounding variables, and anything with a univariate association of p.1. So they did the univariate analysis, which was the one I characterized as taking your 50 variables and trying to correlate them, for example, with an adverse cardiac outcome. And anything that showed up at the 0.1 level went into this stepwise binomial model. And they did a two-tailed test of significance. And you remember that means that you'll accept an outcome that's positive or negative. All right, here's what they found. These are cumulative incidences. This is anything that occurred during the 2-year follow-up, cumulatively. Could have occurred immediately post-operatively, could have occurred at 23.5 months. You see that there is about a 17% of hematological complication, about a 13% cardiac, and so on for urologic, neurological, pulmonary, and GI. A lot of complications. For each of the complications, you'll find tables like this in the paper. So this is the univariate association of all of these variables with a cardiac complication. This is its p-value, and this is its confidence interval. So you can see that, let's choose one of them, for example, that if your patient had diabetes, they had a univariate risk factor of 2.2 with a p of 0.009 of having an adverse cardiac outcome. Now this huge list of variables suddenly changes to this when you look at a multivariate analysis, and the only factors left in for cardiac complications are age, congestive heart failure, cerebrovascular disease, and the surgical invasiveness index. You can see it really shrunk. And the cardiac complications and the pulmonary complications were the largest predictors of death in the post-surgical period. So a key takeaway from this paper is that when you do a multivariate analysis, many univariate variables disappear. The multivariate method is more robust statistically, and the presence of a variable in the univariate, but absence in the multivariate, might reflect that there's really insufficient power for that particular variable in the big analysis. All right? So you can get a univariate analysis, but when you try and put it all together, there just isn't enough power for that particular factor. Now, what about the limitations? And these are ones the authors point out. This is an observational study without any randomization or study control. Patients with severe medical comorbidities were very likely advised against surgery in the first place. So this does not represent the true estimate of complications in patients, in all patients. It's only those who were recommended and presented for surgery. Several of the fields were recorded as categorical variables, and a good example would be diabetes status. It was recorded as yes or no, when in fact if you had the data, you would really want to have HbA1c in this equation to tell you how bad was the glycemic control in the patient. And finally, there is a possibility that some of the patients had follow-up for complications at an outside institution, and that's always present and you cannot track it. Okay, Jacques, how'd I do? Great. Would you have any comment about your involvement in the paper and how it went?
Well, my involvement, because it's fine registry was before me, I kind of had a great opportunity to kind of walk in and help a lot. And as you mentioned, the meat of the paper was really in the statistical analysis, and with that I couldn't really offer too much expertise. So we really, Amy was absolutely, totally essential in that.
Great. Jen?
Jacques, do these include trauma patients, or are these just elective spine?
No, it included everyone. Trauma, tumor, degenerative.
Because on that first table where it shows the people that were excluded, I mean, polytrauma in a 60-year-old is a significant elective 60-year-old. I mean, in that registry, do you guys account for polytrauma? Like, are there other associated injuries included in that too, or just pre-existing medical?
I don't think the polytrauma was included in that. Like, no.
That would be a great covariate and a really important one, you'd think, because if the patient has multiple system injuries, involvement.
The biggest predictor of death was pulmonary. Do you think somebody who has multiple long bone injuries?
Yeah. All right. So there it is. Thanks, and congratulations on being a co-author. Bill Ledoux. Bill, you're on.
All right. Thanks, Peter. Today I'll be talking about my collaboration with Bruce Sangeorzan, looking at using cadaveric gait simulation to conduct orthopedic foot and ankle studies. I work over at the VA Center of Excellence in Limb Loss Prevention at the VA hospital. There's a group of us, 5 independent PIs working together. Here's our website. Our name is what we do. We're the Center for Limb Loss Prevention and Prosthetic Engineering. Half of us work on the prosthetic engineering side, and half of us work on the limb loss prevention side, and that's where I am. When we speak of limb loss, we're really speaking of 2 types of limb loss. There's functional limb loss, so you have a foot that no longer works properly. When we're talking about that, we usually look at aberrant foot shape, flat feet, high arch feet, or ankle OA. And we usually use cadaveric gait simulation, or more recently, biplane fluoroscopy, to look at these feet. I'll be speaking today primarily about our cadaveric gait simulation work. And of course, there's anatomical limb loss, and that population is primarily due to diabetes. And the methods of studying those types of limb loss are primarily cadaveric tissue testing, and we've got a patient-specific computational foot model. So when you're interested in studying part of the body, there's really 3 ways you can do it. If you can measure something on a living subject and get it accurately and repeatably, that's the way to do it. Unfortunately, there are certain things that are unethical or impossible to measure on living subjects. If you want to do the same surgery with 5 different increments, you could not do that on a living subject. Hence, that opens the world of cadaveric research. But even with cadavers, there's certain things that would be hard to do. If you're interested in how diabetes affects the soft tissue, and you want to look at making it 10% stiffer, well, you can't do that with cadavers, and that opens the whole world of computational foot modeling. And again, today I'll be talking about primarily Bruce and I's work on the cadaveric gait simulator. So we've been working with medical students, residents, and fellows. I'm going to emphasize primarily that work with the medical students. You may or may not be familiar with this, but the UW has a Medical Student Research and Training Program, or MSRTP program. Over the last 11 years, we've had 14 students rotate through our lab. In fact, I just see one in the background now, Ahmed. And 11 of them have done cadaveric gait simulations. We ask each student to present at an orthopedics meeting, usually the ORS, but we also had students go to the AOFAS and the AAOS. And then we also asked them all to present an article at an orthopedics journal. We've had articles in JBJS, JOR, and Foot and Ankle. Foot and Ankle is where most of them wind up. So I'll begin today, after the introduction, by talking about the ways of quantifying foot kinematics. That's the primary outcome from our gait simulator, and I'll show you how you can do it in addition to gait simulation. Again, living subjects, if you can do it in a living subject, that would be wonderful. This is a model we've got in our laboratory. There are lots of articles out there, lots of groups that have retroflective marker models looking at foot motion. The main problem with these models is, well, first of all, tracking all these markers. Second, getting enough markers on the individual bone of interest. And then lastly, there's a lot of skin artifacts. So these markers move relative to the bones. Here's a more clinically useful model we've got in our lab that involves 16 markers. We take off these medial ones and only track 11 during the motion analysis. Just a few visuals of an actual foot. My foot is the demo for all these slides today. And I want to point out that my vestigial 5th toe here, which is actually turned sideways, didn't realize that, but it's not really even purchasing the ground when I when I walk. Here's some high-speed video, and what I want to point out here is the motion of this marker at heel strike. Just a lot of skin motion artifact, a lot of motion between that marker and the bone underneath it. Normally we take off the medial markers, but I kept them on just for the video purpose. Early heel off on this subject. Again, it's me. And then I also want to point out the large dorsiflexion angle here. It looks painful, but it actually is not. So high-speed video is great, but it's not actually published in most research studies because it's very qualitative. You really can't quantify much when you're doing this. So to get back to quantitative motion analysis, people have looked at embedding metal beads into the bones of interest and then moving the bones through the field of view, through a range of motion. It's very quantitative, but the problem here is that it's highly invasive. Some groups, including ours, have looked at using CT scans to quantify foot shape. This is really foot shape, not foot motion, bone motion, because you're getting a static snapshot of different foot types. We've also used MRI to quantify foot motion. This is a composite video of 8 different MRI scans of the same subject, moving through 8 different positions. The main issue here is that it's time-consuming. It took about an hour and a half of scanning to get this data. And of course, it's not really walking. It's really just a composite motion of 8 static snapshots. Probably the gold standard for quantifying foot bone motion is using bone pins. This is some work out of Tony Arndt's lab. I'll show it in slow motion here. They actually have 10 bone pins in 10 bones of the foot. I would not want to be that patient when you actually kicked one of the stands with your other foot. This was done in Europe. You probably couldn't do this in the United States, and all the co-authors were their own subjects, so they did it on themselves. So again, this is the gold standard for foot motion, which you really obviously can't do this on a clinical patient population. Other groups have looked at single-plane fluoroscopy. This is some work from the mid-90s. It's kind of noisy, but this is from work of Dirk de Klerk. It's a barefoot heel strike. And he also did some shod running studies. More recently, groups have used single-plane fluoroscopy to try and quantify three-dimensional motion. The issue there is really, it may work well for arthroplasty components, but it doesn't work that well for actual bones. So you really know well what's happening in the sagittal plane, but it's hard to track what's happening in the two outer planes. Well, recently some groups have looked at biplane fluoroscopy. Here's the work of 2 groups. The main issue with these studies is that it's hard to walk through or impossible to walk through these 2 systems and get a normal motion analysis. Our group has begun to work on our own biplane fluoroscope. Here's same idea as the last 2 systems. We use 2 C-arms and we take them apart basically and mount them to these special posts. So here's the X-ray generators, and there's one II, and the other one is actually on the floor over there. Here's our foot phantom. The person walks through the field of view like this. And we've gotten rid of the C's. You can actually get a normal motion when you're walking through the field of view. Here's some early preliminary data from our group using a foot phantom. So this is just a collection of bones that were glued together and wrapped in polyurethane. So it looks like a foot, but there's no actual motion between the bones. But you can appreciate how we're able to open up the metatarsals by having these cameras at oblique angles. And then also some early uniplane fluoroscopy data. Again, this is my foot. We were after, this actually is holding the plywood on the floor. It's not really there. I'm not walking on it. It's just a perspective angle of the, we're using these metal beads to actually track the motion of these beads relative to the skin. This was sampled at 1,000 hertz, early heel off. And again, I want to point out the large dorsiflexion angle between the first met and the first metatarsal. We're checking the motion of these beads relative to the bones to see how much shear there was when you walked. And again, this looks painful, but it wasn't. And we also have some data from same person looking at the different field of view. The foot was too large to fit in the 12-inch II. So this is a heel strike. And I want to point out the large amount of mid-tarsal joint motion once the heel comes off the ground. We were quite surprised to see how much motion there was there. So right there, kind of opens up as the foot comes off. So this is really the way of the future. We currently don't have our biplane system working. We're developing the software still, but we're very close. So to summarize, the existing methods of quantifying football motion, there are skin-mounted markers, there's high-speed video, there's X-ray stereophotogrammetry, CT, MR, bone pins, and fluoroscopy. There's all of these different techniques have issues. And even if we had the biplane fluoroscopy system working properly and perfectly, there'd still be a need to do cadaveric gait simulation. Again, because there's certain things you cannot do on living subjects. So I'll spend the rest of my time talking about our work on the robotic gait simulator, both how we developed it and then how we used it to answer pathologic foot kinematics and kinetics questions. So before I got to the VA and to the University of Washington, our group had been working on static gait simulation, I think since the mid-90s. And this is the work that I became involved in around 2001. This is version 3 of our static tester. And basically, you apply a compressive force to the tibia, and you pull up on the appropriate tendons with actuators that were 5 feet above. These Polumis sensors track the motion of the bones of the foot, and they were very sensitive to metal, so we had to get the metal out of the field of view. We wound up with, I think, 5 articles published. These are all med students who rotated through our laboratory, and including Soren Olsen, who was our first student. The problem with these systems is that they basically are only static snapshots. We primarily looked at mid-stance. So moving on to our gait simulator, the idea behind this is you take a person through the motion lab, you have them walk through our gait lab, and you track their tibia relative to the ground. You have the ground reaction forces and the motion of their tibia relative to the ground. You then take the kinematics and invert them, so now you know how the ground would move relative to the fixed foot, and you bring that information into the to the cadaveric testing laboratory, where we have a robot with a force plate mounted on it, and then we move this force plate, which simulates the ground, relative to the fixed foot. The whole thing is supported by this large 1-ton mounting frame, which also supports our linear actuators that pull on our tendon cables appropriately. And then we also have a Vicon system that tracks the motions of all the bones of interest. And the way we adjust our system is that we basically keep the kinematics same. So we keep the force plate moving in the same angles, and we adjust the position of the force plate, move it closer or further away from the foot, and then we increase the tendon forces to get the right ground reaction force beneath the foot. So here's a video of the robot in action. You may have seen Peter's laboratory. He has the same robot that we have. We put the force plate up here and then move that force plate relative to our fixed cadaver foot. And then here's an actual picture of our laboratory, where here's the robot right back here. Here's the top of it. There's the force plate, cadaver foot with the markers on it, the Vicon system around there, tendon actuators, and our large support frame. Go ahead.
Do you ever apply the fluoroscopies to robots?
We have not, primarily because it would be very hard to get it around the robot. There's really 2 issues. This is a corner of our lab, so we couldn't put the fluoroscopy around it. And then even if we could do that, we'd have the issue of shooting through the metal. So our fluoroscopy system goes through a carbon fiber floor. We do have a C-arm. Yeah. We do have a C-arm. I'm sorry, to validate the foot model on the robot? Well, so the Vicon system is accurate within a millimeter. So we know where the markers are, and we know the markers are not moving relative to the bones. So that's, we're fairly confident in that. We are confident in that.
The validation is really moving things better in the biphilm lab based on the marker movements in humans versus the marker movement in animals.
Yep. Thank you for asking the question. If you have any questions, please just stick your hand up and let me know, and I'll stop. So version 1 of our system involved testing the robot with a prosthetic foot. Again, the robot and the force plate. This was a very simple not simple, but our first attempt at simulating motion analysis. This is the actual ground reaction force of an amputee that we got in our laboratory, kind of a non-standard ground reaction force, but this is how he walked. And then we just told the robot to mimic his ground reaction force. We were able to do this in 1.5 seconds. It was our fastest simulation. So it's getting in position. It's winding up now, and then I'll tell you when it starts. Right now. So about 1.5 seconds to go from heel strike to toe off, which is still about 2.5 times too slow. So the rest of the work involves using actual cadavers. So version 2 of the gait simulator involved adding tendon actuators and the Vicon motion analysis system around the system. This was the work of Lyle Jackson, who was another med student rotating through our laboratory. And for our first attempt at controlling the system, we basically, the first half of the gait cycle, we moved the force plate closer to increase the ground reaction force. And then the last half of the gait cycle, we pulled in the Achilles tendon to increase the ground reaction force. It was a static simulation. We basically did 10 static positions. And since it was static, we could apply the forces and tweak the machine until we got it right. So our ground reaction forces were spot on over the 10 different positions. And the clinical question we're looking at here was we're trying to simulate a flat foot. So this is the lateral tailor-metatarsal angle between a normal foot and then a flat foot. And you can see that the lateral tailor-metatarsal angle is dorsiflexed in the flat foot relative to the same foot in a normal condition. We made the foot flat by attenuating some of the ligaments in the arch. So version 3 involved the work of Ahmed Bayomi, which was published 2 years ago or a year and a half ago in JBJS. And here we added a Novell pedal insole to actually measure planar pressure beneath the foot. And we changed our controller. I won't spend any time talking about the controller, but this was basically a little more sophisticated controller than we had tried previously, than the static controller. The idea behind this was we were interested in fusion of the great toe joint. There's an optimal angle here to fuse it at. And the literature said it was somewhere between 20 and 25 degrees, but no one had actually quantified it. That was Bruce's clinical impression too. But we couldn't find a study that actually quantified the effect of having two dorsiflex or not dorsiflex enough. So basically, Ahmed developed a system where we fused these metal bars to the hallux into the first metatarsal, and we had 7 of them at various different angles. Here's just an overview of our controller. Basically, there was 2 things we changed. The position of the calcaneus in millimeters. So as we increased the position of the calcaneus, we got closer to the foot. So as the force plate got closer to the foot, our ground reaction force peak went up, the first one. And then as we increased Achilles tendon force, our second peak went up. So the target was our green ground reaction force. And then here are all 95 trials that we collected. Now we weren't trying to set the timing up at all, just looking at the peak forces, which were both around, this is about 6% off, and this is about 2.5% off. And the results, the clinical results were that, not surprising, there was an angle that was optimized. This is the peak pressure beneath the hallux, and as you increase dorsiflexion angle, the pressure goes down. And the inverse relationship was true for the first metatarsal. As you increase dorsiflexion angle, the pressure goes up. The 2 lines crossed at 24.7 degrees, so it actually supported what was thought in the literature. So a video of our simulator. This is the pressure met right here. So look at the high peak pressure at the hallux push-off. Of course, because the hallux cannot not dorsiflex at all, it's fused or simulated fusion. Show that one more time. Okay, so version 4 of our simulator involved the main difference was changing the controller, making it a more comprehensive controller. And I won't spend any time talking about that. The idea of this project was basically looking at the effect of a long second metatarsal on the crossover toe deformity. If we took normal feet and made their second mets longer, could we increase change the angle of the second toe relative to the first toe? We weren't able to change the angle, but we were able to increase the planar pressure beneath the foot. Again, the ground reaction force, the gray is our targets, the red is what we were doing the summer before with Ahmed's work, and the blue is with our more robust controller that was really the same method as Ahmed's for the first half, and then a more sophisticated method for the last half. So we're right on for the second hump. Basically, the Achilles tendon force was working very well during this version of the project. Again, the clinical question was, what happens if you make the second metatarsal longer? How can that affect both the angle of the second toe and also the planar pressure beneath the toe? So here's 1 foot with a normal planar pressure distribution, and here's the same foot with an 8 millimeter spacer, stuck in here between the second metatarsal, making it longer. See the large increase in force beneath the second met. And looking at all 6 feet in the study, there was a strong correlation between increasing the planar pressure, increasing the metatarsal length also led to an increase in the planar pressure. So the videos got more and more complicated as the simulation got, as we developed our system. This is still a 10-second simulation. We're tracking the motion of just the toe and the second metatarsal. So except for the behavior of the toe itself, it looks, the great toe, it looks quite normal. All right, the current version of our model is what we're calling version 5. And basically here we improved our controller and we added a full kinematic marker system to our foot model. Patrick and Eric were two engineers working in a laboratory. They basically described the controller and then described the results of the kinematic system. I won't be going into those papers at all, but I'll be talking about how we used the version of the model to answer a couple of clinical questions the last few summers with med students. Now our ground reaction force is pretty much spot on for both the first peak and the second peak. And our tendon actuation forces, the light black is our target and the solid black is our what we achieved, and it's again spot on. So the system is working quite well. So again, the videos got more and more complicated as the grad student got more and more polished. So this is our fastest simulation with a living subject. I told him he should have added the Chariots of Fire theme song to this. So about 3.2 seconds with a full kinematic marker system. We're using 3 things to control it. We changed the tibialis anterior force early in stance. So these are the 3 outputs. 3 things we can control, I should say. The Achilles tendon is late in stance. The position of the robot relative to the calcaneus is early in stance, and so is the tibialis anterior force. And then here's our ground reaction force. So the blue, the gray is the target, and the blue is what we actually achieved. And so you'll see this move early, in the middle, and then late. And then we're able to check the force very well. So the questions that we're answering with our current system are, Darren Trask was a med student 2 summers ago, and his study was using the same jig to modify the second metatarsal, now looking at 2 different osteotomies. The distal to proximal osteotomy and the proximal to distal osteotomy. With the distal to proximal, if this angle is not just right, you can actually wind up increasing the plantar pressure beneath the second met. And then with the proximal to distal, you can actually overcorrect the plantar pressure. What we found here, the solid lines, this is the plantar pressure for the first met, for the second met, and the third metatarsal. So the plantar pressure decreased no matter what surgery we used on the second metatarsal, but the dorsal to plantar, proximal to distal surgeries, which are the solid bars, had a greater reduction in plantar pressure than the distal to proximal, which is what we expected. And then last summer study, which we're still analyzing, was looking at the effect of the FDL tendon transfer when you have a posterior tibial tendon dysfunction. And we simulated 3 transfers. The tibialis posterior insertion was basically we just pulled in the tibialis posterior with the force that we would have applied to the FDL. And then we took the severed FDL and attached it to basically a screw, a hanger bolt that we had stuck into the navicular, and then moved that to the medial cuneiform. And what we found was no matter what surgery we used, we were able to shift the plantar pressure. So this is plantar pressure relative to flat foot, and these are the various locations beneath the foot. We're able to reduce the plantar pressure in the increase the plantar pressure on the lateral side of the foot and reduce the plantar pressure on the medial side of the foot. So we're actually increasing the, return the arch to its normal position. So my last slide here is really just talking about some of our future work and ongoing projects. This is looking at flat foot reconstructive procedures with a lateral column lengthening and a Z osteotomy. We've done a few feet to date. This is a pair of flat feet. There's the left foot here and the right foot here. On the left foot, we did a lateral column lengthening. So very high pressure beneath the metatarsals after the surgery. And then on the right foot, we did a Z osteotomy, and the pressure was increased, but not as large as the lateral column. So this is a very promising result for us. We're going to be conducting this study hopefully next summer. I want to acknowledge Patrick Godwin, who basically built the system for us as part of his PhD thesis. These are all the engineers who worked on the project, and then these are all the med students who rotated through our lab working on the dynamic gait simulator. And lastly, I want to leave you with a thought concerning so this was a study that we were doing looking at the effect of foot size on foot function. And I just wanted to point out that no matter how carefully you plan your experiments, you can always wind up with some unexpected results, or unexpected methods. Worked well until the baby got involved. Great. Any questions?
Well, thanks so much. Bruce, would you want to make some comment about the value of your basic science collaboration here?
I think you can't overestimate the value of collaborating with basic scientists because you have clinical questions, they have methodologists. I don't know how many of you saw the article in Wall Street Journal last week. It was 70% of positive results published in major medical journals validated by secondary authors. There's a lot of lack of objectivity in medical research world for a variety of reasons. Working with someone in a different field who's very objective helps to eliminate your own biases and helps to make the end a much more valid outcome. And I think when you're thinking of resident projects, anything that involves anatomy is very translatable. And these projects, maybe Ahmad can comment, but these projects that we pick for the medical students, we try to make very, very discrete projects with a single variable because they only have, how many weeks do you have? 8, 10 weeks?
Aaron.
And so tell us, how many weeks did you spend after your summer period trying to get the paper and everything else done? How long did it take after that?
I think we spent about 14 weeks in terms of developing the methods of the data, and then sometime in the fall, and obviously had great input from Patrick and Dr. Sangeorzan to the data.
And I'm going to give a talk at the ORS that week, so that's split into March.
So it's very good to establish a track record of working, and Bill's got all kinds of great tools over there that can really validate every aspect of what you're doing. So think anatomy, think of discrete things, think of things you're really curious about when you're trying to come up with this subject for a student project or a resident project. If you're interested in it, it's a whole lot easier to get the work done. If you're just trying to get through it, it can seem like a long, long process.
All right, thanks to both of you for a great presentation. So I want to finish this long marathon and let you go here with just one slide about applying for external funds. To do the kind of work that the medical students and residents have done in the presentation that you just saw, it makes a big difference if they can actually bring some funds to the effort. To buy cadavers, to buy implants, to buy materials, to buy software programs, to buy access to databases. And you know that we have instituted now this internal resident research grant program, and you also heard this morning that if your faculty are particularly non-compliant this year, which we in some ways hope they are, we'll get much more money for resident research. So they'll be penalized and it'll come to you. However, there'll be other ways to get you money too. But we also hope that you will exploit fully the possibilities that are in the literature that are out there on the web for research grants. And I've chosen just a few here. Here is a grant from, whoops, we're not getting clicks here. I think I better put my connection in. Just a moment. Yeah, I've unhooked my dongle here.
While he's doing that, I think I can talk I gave out IRB. If you happen to be with a faculty member who wants to use an IRB,
I don't have it here.
Outside of the normal people who submit them for it, if you want to do it yourself, there is a separate form for a chart review. Infinitely faster than even the expedited IRB, and you can get waivers on HIPAA and consent if you use that special form. A lot of the faculty members don't know that, so it's hidden in their website. You actually have to search for it.
I can email it to you. I have it.
Yeah, it's on the chart review.
Thanks, Jen, for pointing that out. I also want to let you know that we are interviewing right now an IRB person whose sole job, it will be 50% job, to just do IRBs for our faculty and residents. So that'll be also another big change. So I'm going to email you this presentation together with the one you just saw, but if you go to any of these links, one for OREF, which Jen got last year, and another one, we got a journal grant from OREF, so these things are very achievable. They've been achieved by your peers. American Society for Surgery of the Hand, we have a grant for that. Adam, I think you had one, is that right? Yeah, so Adam had one of those. OTA, I don't think we've had a student OTA grant, resident OTA grant in the last couple of years, but we really should. It'd be very competitive coming from here. I just saw this one. It's only $2,000, but this is more like money in your pocket for presenting a paper on arthroscopy at a meeting. So there are many opportunities, and I'm going to be working with all of you this year to try and maximize what you can bring into the department. My office can help you do this. We are experts at getting grants out. I didn't say getting grants, I said getting grants out. We need your help to get the grants so we can move grants out the door. So I would encourage you to think about these opportunities, and let's see if we can increase the revenue that comes in for you to use for your research.
The OTA had a really good fundraising year for the research coffers a year and a half ago, so that would be the fullest bucket to try to get money from at the present time. And I and other members of our faculty have sat on that committee and have a general idea of what passes muster on that committee. So we can help you out with what Cavanagh can offer others who can help.
That's a great offer. Okay, so that's it. That's the finish line. And I want you to give me some feedback about the things we're doing here. These sessions are designed for you, and I'm trying to make it so that I bring information that will stimulate your research part of your brains, give you some information that will help you professionally. Keep the feedback coming so I can continue to tailor it to your needs. Okay? Thanks. Have a great week.
Thank you.